Hello, folks. Welcome back. Let's continue with the immunotherapy of allergic rhinitis. Immunotherapy, it is the one and only treatment which is going to entirely change the history of allergic rhinitis. And that means it is going to cause a long-term remission of the disease after completing the therapy. Okay. So this is basically is a sublingual or subcutaneous injection. Um, there can be risk, and the risk versus benefit is considered always. Risk may include there can be anaphylaxis reaction, allergy. Allergy, yeah, anaphylaxis almost the same. Then there is a lot of time exposure to these immunotherapeutic agents. This is a big uh, thing, but the benefits at times, if the patient is having a very severe reaction and their quality of life is affected, it is always better to consider immunotherapy in these kind of patients. And we warrant this therapy for patients having moderate to severe persistent symptoms. They have failed all sort of conventional therapy or even oral corticosteroids they tried and they are not going to help. And also the patient cannot avoid any kind of allergen exposure like occupational exposures or anything like that. In those cases, immunotherapy is warranted. And also in children, immunotherapy is very helpful to prevent asthma, prevent the development of asthma. Okay. Um, there can be some sort of problems, but development of new allergies can be prevented, or allergic rhinitis, the severeness may reduce, and asthma would not be developed. These are some advantages of immunotherapy, but it has its own side effects as well. So, very importantly, they are taken as subcutaneous or they are taken sublingually or as a subcutaneous injection. Next, class of drug are nasal anticholinergics. Why? Why we use anticholinergics here? It's because it has some effect on rhinorrhea of the allergic rhinitis. Only in rhinorrhea. Why? Because all secretions, even salivation, lacrimation, in just gastrointestinal secretions, bronchial secretions, everything is inhibited in the adrenergic system. Whereas in cholinergic system, all kind of secretions are stimulated. So when anti comes, it is opposite to that of cholinergic system. So I said cholinergic system, all secretions are stimulated. But when it comes to anticholinergic, secretions are not there. That means it can help with rhinorrhea only. And what we can see, the most common drug is a nasal ipratropium bromide spray. Ipratropium bromide nasal spray. Usually, this ipratropium bromide inhalers are used, antimuscarinic agents. They are used in COPD and also in asthma cases where bronchodilators, normal bronchodilators, beta agonist are failed. But here also, for severe rhinorrhea, this nasal spray can be suggested. Now, as I said, LTRAs, leukotriene re- receptor antagonist, which is montelukast. Okay, Montelukast. This drug can be considered as a second or third line. In India, you might have seen levocetirizine Montelukast tablets. But most nowadays researchers has done, and they say that it is not important or it is not ideal to use Montelukast straight away. It is, we have to try with antihistamines first and then move to LTRAs or Montelukast because they can cause a lot of side effects, including neuropsychiatric side effects like depression, tantrums, temper, suicidal thoughts, nightmares. All these problems have been reported with this Montelukast, and they are metabolized by CYP enzymes like CYP2C9, CYP 3A4, CYP2C8. The 3A4, even the grapefruit juice can inhibit the metabolism of this drug. Even just the grapefruit juice. So it can be used as a second or third line if the patient has concomitant asthma. And they block the effects of leukotriene, which facilitates the allergic rhinitis and asthma. You know where the leukotriene receptors are acting? I will show you. We have something called arachidonic pathway. Okay. So arachidonic pathway means membrane phospholipids. This one you're going to study in NSAID's anti-inflammatory chapter, but I'm just giving you a heads up or to understand what is this leukotriene receptor antagonist. Membrane phospholipids are converted to arachidonic acid by phospholipase A2. That is, we studied PLA2. Okay. And this one enters into two different pathways. Cyclooxygenase pathway and lipooxygenase pathway. So the cyclooxygenase pathway is responsible for prostaglandins, thromboxane A2, and everything. Whereas lipooxygenase pathway is responsible for the formation of leukotrienes. There are a variety of leukotrienes and a variety of prostaglandins as well. So this leukotriene receptor is blocked such that, and this is mediating allergic reactions, bronchoconstriction. That is the reason why they are being used in asthma. These are mediating inflammation. And see, even the steroids, the corticosteroids are inhibiting phospholipase A2 such that membrane phospholipids are not converted and they do not enter these pathway and cause inflammation and allergy. Now you might have understood what's going on. I believe so. Okay. And that's all about the drug therapy. Now, what to select? As I said, the first line is second generation antihistamines. Corticosteroids are first line. If not effective, the combination, nasal corticosteroids and antihistamines. In mild cases, you can use just a corticosteroid if it is persistent as a first line therapy. Moderate to severe combination, sometimes if not helping with that, systemic corticosteroids. Now let's talk about two things. One is pregnancy, breastfeeding. Not just two things, we have three things. When after breastfeeding, they grow up to Children, we need to talk about them as well. Pregnancy, if you ask me, first line is allergen avoidance. If it is a known case of allergen, avoid it. It is safe. And then when it comes to drugs, first line, intranasal corticosteroids, which is safe and effective. You can use fluticasone propionate, budesonide, beclomethasone, okay? Fluticasone, beclomethasone, budesonide, and never ever triamcinolone because it can have teratogenic effect in the first trimester. Okay, and chlorpheniramine is not used because it is sedating, and we suggest intranasal decongestants. Can use intranasal decongestant, not oral. And another thing, intranasal decongestants can be, or ocular decongestants can be used. Also, cetirizine and loratadine can be used. They are non-sedating as well. And very importantly, avoid pseudoephedrine as well. Pseudoephedrine is a problem. Okay, ephedrine, it is a problem. And when it comes to breastfeeding, as I said, you can use first line and first and second generation antihistamines. I'm sorry about the sound. You can use first generation and second generation antihistamines, but you have to avoid belastin and ripatidine. They do not mention which trimester, but they should not be used. And when first generation antihistamines or cetirizine is used, always try to monitor for some sort of somnolence in infants. It is better to use intranasal corticosteroids. Intranasal corticosteroids. Sorry. Are preferred over intranasal decongestants. Okay. And in pediatric children, age greater than 6 months, cetirizine, then less desloratadine. If it is age greater than 2 years, fexofenadine, loratadine can be used. Second generation is always preferred. As I said, corticosteroids, nasal, greater than 2 years. Okay, and no decongestants. No decongestants less than 6 years. Sometimes you can use some intranasal saline or sprays. Okay, so these are the agents which we can use for these cases. I want to ask you a few things. I know this is not a live session, but still, let us talk about some things. Like when you're using an intranasal, fluticasone intranasal spray, which what are the counseling points which you have to follow? Do you wash your hands before using the spray or no? You have to wash the hands. You have to use a sprayer, this fluticasone sprayer, before saline sprays or irrigation because this can wash away the medicine or steroid. Use your sprayer before saline sprays or irrigation. This irrigation, they should be taken apart because it can wash away the medication or the steroid. And always prime the device. Spray into the air a few times until a fine mist appears, kicking out the air, priming the device. It is very important. Then you really have to blow your nose gently, not stressfully. Gently before using your spray. And then before using the spray, first of all, you have to shake the container several times before use. Because it is propellant gas, in order to distribute the active ingredients, you really need to shake the bottle. For more information and for patient counseling points like this, always follow our shorts. I'm going to post a lot of shorts based on patient counseling points, which is very important for your exam. Thank you so much for listening. I will also be uploading questions, case scenario questions based on this chapter in shorts. I believe you would follow me for this and subscribe to my channel to get more videos and updates so that we can crack the exam. Thank you so much for listening to me. Have a great day ahead or whenever you're watching, have a good time. Stay tuned. Bye-bye.